Hello everyone, my name is Sean Grimm and today I'm going to be talking about a journal article called Predicting Total Knee Arthroplasty from Ultrasonography Using Machine Learning. This was published in 2022. So why did I select this article? Well, I'm a physical therapy technician at a small outpatient clinic in Vienna, Virginia, and I work with people who have knee replacements on a regular basis. I help them through the rehabilitative process. This includes things like strengthening, mobility work, and certain modalities we'll use, so like heat, ice, electrical stimulation. Also, sometimes we do ultrasound, but not for diagnostic purposes, which is the focus of this article, more so for treatment. And so, total knee replacements are a very intensive recovery process. It can take anywhere minimum, probably full recovery, 12 months, see as much as 18 months. And then on the right of this slide, you can see that of a picture of a knee that has pretty bad osteoarthritis, which is osteoarthritis is sort of the predictor for whether or not people are getting a knee replacement. If you have very very severe osteoarthritis, your joints are inflamed and the cartilage is worn down, so you have more so bone on bone, and that can lead to a lot of pain and stiffness. And then what people will do is they'll get a surgery where you can see right here, they put in a plastic spacer and then they replace this part of the femur right here in the sort of the top of the tibia where the cartilage used to be, and that basically helps take away the pain. And there's a whole rehab process that you undergo at PT after you have the surgery done. And then under here, I just have a little bit of an explanation for what osteoarthritis is linguistically. So you can see it's bone, it's at the joint, and it talks about inflammation. And so today, in this presentation, we're going to talk a little bit more about the background. I'm going to talk about the objective of the article. I'm going to talk to you about the methodology, where we'll go the into examining the data that they used, what they did to the data to create the models that they did. Then we'll examine the models and we'll move on to the results and see sort of the interpretations that we can derive from the models that they came up with. And then I'm going to do a couple of takeaways in the discussion, talking about the limitations from the article, maybe future future works associated with ultrasound diagnosis using machine learning can use. And then in the conclusion, we'll just examine a couple more key takeaways. So, total knee replacement usage has risen continuously over the past 50 years. The first knee replacement was in 1968, I believe, and gained popularity in the 70s. And then the surgery really took off in the 90s and the 2000s, became a very regular procedure to have done. I'm sure a lot of you probably know either relatives with total knee replacements or you just have heard about them in talking. So, total knee replacement, the thing about it is that there's been this arguably an overprescription with them. A lot of people are getting them. And I think the important thing in the medical field is that we make sure that we're allocating our resources effectively and we're making sure that only severely affected patients are the ones getting this procedure done, because it is a very resource intensive procedure, both on the provider side, their time and attention is, we need to make sure that we're utilizing a provider's time and attention effectively. And then obviously we're paying the provider lots of money for their time and attention. So just on both the local and the national scale, making sure that we're making the right decision when we decide to take the surgery route to alleviate osteoarthritis in this way. And so the interesting thing is that we can kind of attempt to solve this problem through preventative measures by leveraging machine learning and imaging data analysis. So that allows us to prognosticate osteoarthritis and determine if someone is likely to be a candidate for a total knee replacement in the future. Another thing to note is that radiological imaging, the two main things we'll talk about today, MRI, X-ray. MRI is the gold standard. This particular study, we just talk about X-ray. MRI is very, very costly and inaccessible. X-ray is also. And so basically we need to ensure that we're able to create diagnostic tools that are more accessible for patients, because both on the clinic end and also the patient end, radiological imaging can be kind of gate kept and difficult to utilize if you don't have the resources. So ultrasonography is a more cost-effective and accessible mode of diagnosis compared to other radiological imaging methods. It excels in assessing soft tissues like tendons and ligaments. And today we'll talk a little bit about, how it could be used to analyze the joint, not just the tendons and ligaments. And then when pairing ultrasonography with machine learning, it improves our ability to prognosticate osteoarthritis on a more accessible level. And it also, because of that accessibility, we're able to continuously monitor the joint on like a higher level than we might be able to with the more costly, inaccessible methods like X-ray and MRI. So the objective of this article was to investigate the value of ultrasonographic data in predicting total knee replacements. And the data that was collected in this study was from a prospective cohort study done in Norway called the Musculoskeletal Pain in Ullensaker study, or the MUST. Ullensaker is just a small city area outside of Oslo, Norway, kind of central Norway. And the MUST study included 630 participants with osteoarthritis. Now, these participants underwent an extensive baseline clinical examination, and the data was linked to a Norwegian register, and only individuals without knee replacement surgery were included in this data set. So here you can see a picture of someone getting ultrasound done on their knee. These knee ultrasound exams were conducted using standardized testing, and two experienced sonographers were performing the assessments. They scored various features including osteophytes, the presence of them, meniscal protrusions, synovitis, femoral cartilage thickness or FCT, and quality FCQ, also calcium crystal pyrophosphate depositions. And then inter-rater and intra-rater reliability assessments were conducted to evaluate the consistency of the assessments. For the X-ray imaging, knee X-rays were obtained at a baseline in a standardized view, and the imaging was scored using the Kellgren-Lorentz or the KL Atlas. This rates osteoarthritis severity from 0, which is no osteoarthritis, to very severe for osteoarthritis. Also, in this whole study, we include some clinical predictors, things like body mass index or BMI, knee injury history, familial osteoarthritis history, and also the occupational load. So do they have a job that's very intensive and cumbersome for their knee? The modeling. So the researchers implemented logistic regression as the modeling method to predict the probability of total knee replacement. They did this in Python using the scikit-learn package, and L2 regularization was utilized due to high correlated covariates. So basically a penalty was applied to the logistic regressions. And then there were a couple of different model configurations that we'll be evaluating and that they evaluated. The main sections of variables, there's three main sections. So we have the clinical characteristics, we have the KL grade, and we also have the ultrasound features. So the final model, which is model 4, we'll talk a little bit about in the future. It combined features in an ensemble approach. So an ensemble approach is basically the average of two models, and the two models that were average were the KL grade and the ultrasound features. So those were averaged and then put into a fourth model. Experimental setup. So they utilized nested leave one out cross-validation because it was a low sample and they wanted to make sure that they could generalize well to new data. Model hyperparameters were tuned using a five-fold patient-wise cross-validation loops. So different combinations on subsets of the data to find the parameters that worked best. And then there were thresholds determined for binary predictions. These were converted from probabilities. For the performance assessment, we had the ROC, AUC, and the area under the precision recall curve, or the AP. And then 1,000 times stratified bootstrap with 95% confidence interval. So basically they resampled the data 1,000 times with replacement and computed the performance, and then they estimated the model's performance and its uncertainty with a 95% confidence interval. As for the descriptive findings, so there were a total of 630 participants, 73 of which were excluded, resulting in a sample of 557 individuals with 1,114 knee joints. I'm just going to quickly show you. You can see here, these are all the clinical characteristics that we're looking at: age, sex, body mass index, knee injury, history of familial OA, occupational load, knee pain, and then you have the radiographic scoring section, which is the Kellgren-Lawrence scoring. And then you have the ultrasonographic scoring, which is all of those other features, which we'll talk about. I'll break down a little bit more in the future. And then, so 69% women, mostly women-dominated study, average age of 64.88, and then over the 5 to 7 years, because it was a prospective study, 2.7 of the participants actually ended up going in for a total knee replacement surgery due to their osteoarthritis getting pretty severe. Where are we at? Oh. Univariate analysis. So this is kind of looking at each individual feature and its relation to outcome of total knee replacement of osteoarthritis. So in the patient category of the data, previous injury and familial OA were found to be the most significant predictors, odds ratios of 4.39 and 2.01. Radiological category, we had KL grade was the most significant predictor. It's the only predictor, but it's been the historically it's why X-ray is so good, and it's the gold standard. Well, radiological imaging is the gold standard for detecting osteoarthritis. Ultrasound, we have the osteophytes, their presence, synovitis, FCT, and FCQ as the most significant predictors. And in particular, medial FCT was the most, had the highest area under the precision recall curve among the ultrasound features. So this basically means that if you look at this knee here, the lateral side of the knee is where my mouse is right here. The medial side is right here. And then as for the femoral cartilage thickness, so the femoral cartilage, because the femur is this top bone here, that's the lateral femoral cartilage. This is the medial femoral cartilage. And then the sulcus is in between, underneath this ligament, this patellar ligament that runs right there. So the medial had the highest area under the curve. This area right here, this cartilage, yielded the highest area under the precision recall curve. Leave one out, cross-validation. So in the outer loop, you can see that one subject at a time is removed from the training data. Optimal hyperparameters are searched for on the remaining data, and then 5 models are tested on that left out subject, and this process is repeated throughout the whole data set, ensuring a very robust model evaluation. And this is just a graphic kind of explaining what's happening. Multivariate analysis. So this table, which shows all 4 models and the significance of each predictor. In model 2, we had an area precision curve of 0.2 and an area under the curve of 0.81. Model 3, area precision of 0.17, area under the curve of 0.79. So model 3 was the ultrasound and the patient characteristics, or I just say demo because it was demographic, a lot of demographic categorical data. So it was it fell a little bit behind model 2, which was the x-ray, but still, for it not being considered a gold standard, it held pretty well. And then the ensemble of model 2 and 3, so having the models built of x-ray plus patient characteristics 2, and then the third one, ultrasound plus the patient characteristics, those were both averaged into one model, which was the 4th model that had the highest area precision, area under the curve, and then a ROC AUC, area under the curve, of 0.82. So model 1, the most significant predictors were BMI, past injury, familial OA. Model 3, osteophytes were the main predictor, and then model 4, KL grade was the main predictor. So again, this shows that in that ensemble model, the KL grade was still more of a predictor than the ultrasound, but we still see that the combination of the two actually outperformed the X-ray alone. And then FCT in the sulcus compartment, in the absence of the meniscal extrusion, were significant predictors of total knee replacement across all models. Now we get to the curves and the graphs. So we have the ROC and the AP curves. This is for performance 1 through 3. These represent the trade-off between the true positive rate and the false positive rate, as well as the average positive predictive value. So you can see here that model 2 and 3 are the most comprehensive models. And then move on to the next slide. So models 4 and 5, a little bit confusing. So in this particular slide, in the graphs, they decided to label the ensemble as model 5. And so I'll just explain this. Model 4 is actually a combination of the patient characteristics, the X-ray, and the ultrasound data. So it's a model built on all of those. There's no average being done. It's just a model built on all of those features combined into one model. And then model 5 is the ensemble. So that is the 2 models, the 2 and 3. Sorry if I'm losing you. It's where so we have the second model, which is the X-ray and the patient characteristics. And then we have the third model, which is the ultrasound and patient characteristics. Those are averaged into the ensemble model. So that is model 5 in this particular slide. It is a little bit confusing how they decide to label it that way in this. But so you can see that it's very close. Both are pretty comprehensive models that encompass a big area. But Model 5 actually outperforms Model 4 a little bit, which just means that the ensemble, the average of the two, was uh, more effective. We have the odds ratios next. So just a little review. Odds ratio of 0 means that there's no association between the predictor and the likelihood, in this case TKR, so total knee replacement. If odds ratio is greater than 1, so as the predictor increases, the likelihood of TKR, our outcome variable that we're measuring, also increases. As the predictor decreases, the likelihood of TKR decreases as well. And you can see here our 4 models. So in model 1, just the patient characteristics alone, we have family OA, BMI, and injury, history of knee injury. They're greater than 1. So as they increase, which they are, they correspond to a greater likelihood of TKR. And then in model 2, KLG, which is the Kelgrade scale, the X-ray scale, that means that there's a greater likelihood of total knee replacement. Model 3, everything north of sex in terms of the features. And one thing to note with sex is that since the study was mostly women, 69% women, that may have skewed that as a feature in its ability to predict a little bit. And then model 4, we can see that again, everything north of even FC quality, but sex again, those are associated with an increased likelihood of total knee replacement. So overall, they found after, running the analyses and interpreting the results that ultrasound features actually can predict future knee osteoarthritis surgery cases nearly as well as the KL scoring, with differences that were within expected variability. The ultrasound assessment, it offers a couple of advantages like immediacy and its ability to detect early and kind of constantly. You can't go in for an x-ray nearly as much as you can get an ultrasound diagnosis. And so another interesting thing is that this was the first study to actually consider using ultrasound and machine learning as a prediction method for osteoarthritis, leveraging its ability to identify key features. One of the things for consideration is that maybe in the future we can automate the ultrasound feature scoring process, because they were expert sonographers, but there's still human error, which if we're able to automate that part of the diagnosis, there might be a little bit more consistency across the feature scoring. A couple more areas for consideration. So this was a relatively small data set. It was only 557 individuals that we absolutely included, down from 630. And then the researchers actually mentioned that they had a little bit of missing ultrasound data. And this could be also explained by how there were a couple of subjects that they only had osteoarthritis in one knee. They didn't have it in both knees. And so this caused a little bit of an imbalance in the data. So they would only they would treat each knee in each subject as a separate case. They wouldn't, for if you had 2 subjects, one that only had osteoarthritis in one knee and the other had in both, the one that had in both, there would be 2 instances on the data set, for one for each of their knee. So just potentially could create some statistical complexities, and maybe this could be designed a little bit differently in the future to account for that. Another thing is that knee pain could be used as a future feature for prediction. So this is a subjective categorical measure that, could be used by just giving the patient a survey, but it could if a patient is feeling that they have pain in their knee, it could be a very good indicator that maybe they are a future candidate for a total knee replacement surgery. They are experiencing some symptoms of osteoarthritis. Another thing to note is that a doctor of physical therapy at my clinic, I was talking to her about this journal article, and I asked her for her input on it, and she mentioned how um, this kind of goes hand in hand with the previous thing I just said. A lot of patients don't end up seeking help until they really start to begin to experience symptoms of pain, until they really speak up about it. So part of the problem with that is that if if they wait until the very last minute to seek diagnosis, it might be too late. And the whole kind of meta takeaway from this is that we want preventative medicine. We want to be able um, to only have to use invasive surgeries when we really need to. We uh, we don't want to overprescribe them, and we want to be able to have other modalities of ensuring healthy people. So, my key takeaways about this article is that it did a good job at highlighting the growing concern of the increasing incidence of total knee replacements. And it also brought to light how early stage prognosis through predictive models is very important. We need to make sure that we're diagnosing osteoarthritis early on, as early as we can, and monitoring it as much as we can. And we can do this, like they mentioned, through low cost and more accessible tools like ultrasound. Um, almost it's almost just as good, as those radiological methods like X-ray, MRI, and especially when combined with the features from radiological methods and the patient characteristics, it can predict nearly as well. It can predict oftentimes better when it's combined, the likelihood of total knee replacement. So I just want to thank you for listening to my presentation, and here is my email. Like to contact me, my LinkedIn, and then this is a QR code for my personal website that I'm building. It's a little bit under development right now, but I'm working on it. So thank you so much for watching, and I hope you have a nice day.